Atrial fibrillation. What exactly is it? What happens? And what are the complications? How do we manage it? How do we detect it in the clinic in the first place? So atrial fibrillation essentially is whereby the atria are undergoing fibrillation, exactly as it says on the tin. And I'll explain fibrillation in just a moment. Let's just appreciate the atria and the ventricles, the two chambers at the top being the atria, the two at the bottom being the ventricles. Remember, the apex is at the bottom, the ventricles, and the base is at the top where the atria are. We can also have ventricular fibrillation. Now, VFib is significantly more of an emergency, and it is more life-threatening by far and large. VFib will generally predispose you to a cardiac arrest. AFib, on the other hand, atrial fibrillation, relatively common and not as catastrophic an event as VFib. So what exactly happens? Let's appreciate that the atria are going to contract. They're going to contract as normal, and in doing so, when they do that, they will empty the blood that pools inside and accumulates inside there. When you contract fully, they're able to empty of the blood that accumulates inside there. In fibrillation, however, what happens is rather than contracting completely like so, what happens is the atria fibrillate, they quiver. And notice how fast this can quiver. The rate on atrial fibrillation generally will be up as much as 300 beats per minute. In atrial flutter, which is a slightly different, one could argue variation, but it isn't a variation in its entirety. The rate can go to about 150 beats per minute. Now, when the atria are fibrillating like so, they are quivering, and because they are quivering, they are not entirely completely contracting. Remember, in order for it to contract fully, the atria has to depolarize completely. Now, due to the fact that it's not completely depolarizing and therefore not completely contracting, when we look on the ECG, you will not be able to identify any discernible P waves. Recall, the P wave on the ECG is due to the atrial depolarization, and that's what will happen here. So you will not have any discernible P waves in atrial fibrillation. Generally, we look at all ECGs firstly in lead number 2. So there are different types of AFib. The first being paroxysmal, which generally lasts less than 48 hours. There's transient, which lasts for up to 7 days, also otherwise known as persistent. And then after that we have long-standing, which will last for more than a year. Now, it depends on what references you read, but the point being that just because a patient that you examine has clinical indications of AF doesn't mean this is new. It could be actually pre-existing. So therefore, you've got to appreciate and work out whether this is new AF or pre-existing AF. And that's because you've got to manage it if it's a new finding. What you may find also, if it's a new thing, is this in the given context of, say, for example, an infection, because infections may well predispose you to AF. Now, what exactly happens in AF? Very briefly, what happens is that you've got your cytoatrial node, which is your pacemaker, found generally in the right wall of the right atrium. It's going to send a wave of electrical excitation along the atria, and across from the right atrial wall, it will go to the left atrial wall via the Bacchus plexus, and you will get that depolarization. Now, in the context of AF, what really happens is, amongst a number of other things, in brief, is that you have got a number of foci which are generating that electrical impulse. And so therefore, rather than the impulse coming from one set of nerve cells, i.e. the sinoatrial node, you've got a number of foci that are doing the same thing all simultaneously. One could say too many chiefs in the or too many chiefs altogether, and because of that the messages are mixed, and so therefore the atria don't depolarize entirely, and so you don't get the full contraction. How do we pick this up on a clinical situation? Well, in a clinical examination, when we assess the patient's pulse, remember we are looking for the rate, rhythm, character and volume on your pulse. What you'll find is that the rate is incalculable, and the reason is because it's not regular. What you have, rather, on the contrary, is that you will have an irregular heart pulse. That is different to a regularly irregular pulse. I'll go again. AF, irregularly irregular, which is different to a regularly irregular pulse. A regularly irregular pulse is indicative of atrial flutter, something I mentioned earlier on. That generally has a resting heart rate of about 150 beats per minute. So in the context of irregularly irregular, AF, what you'll find is that there is no consistency in this beat, and therefore you are unable to determine the heart rate. Why is this clinically important? Well, if you appreciate a moment ago, I suggested that the heart is quivering. The atria, rather, are quivering. Now, with a quiver, as compared to complete contraction like so, here, the atria are emptying completely of their blood. In the quivering situation, in the fibrillation situation, they are not contracting entirely. So therefore, we don't see the P waves. But also, the blood actually accumulates in the atria. It remains stagnant. And in doing so, it's going to allow it to become coagulated. And that coagulation will lead to the formation of a thrombus. Leave blood alone standing for about 20 minutes and you'll see the coagulation occur. And that's precisely what happens here. You will then develop a thrombus, what we refer to as a mural thrombus in the atria. And that thrombus has a potential then to continue in the circulatory system and go into the common carotid artery, followed by the internal carotid artery as it branches off, and inevitably enter the circular Willis. And in doing so, it will demonstrate or manifest itself clinically as a stroke. So patients who have AF, atrial fibrillation, are at risk of developing a stroke. And that's the real problem or the concern, the complication over AFib. AFib alone itself isn't massively disconcerting or otherwise worrying, but the complication is. And that, like I said, is that of a severe cardiovascular accident, namely a stroke. Here, of course, we're referring to an ischemic stroke, not a hemorrhagic stroke. Again, separate video on strokes which I've done, and you may refer to that for the ins and outs of that. So what do? Well, we need to manage this. So if the AFib is identified as being long-standing or otherwise longer term, then we need to put the patient on some anticoagulation therapy. Nowadays, what we'll do is we'll use the likes of apixaban or rivaroxaban, and we'll put them on lifelong so as to prevent the formation of a mural thrombus, which will then predispose you to a cardiovascular accident, namely an ischemic stroke. Thank you for watching.